Good evening, everybody. How's it going? Want to do a quick sound check before we get going. Everyone, please comment in the bottom if you have any trouble hearing me or seeing me. So this is our first time to do this on YouTube. So we may have some hiccups, technical hiccups. Hopefully not. I don't anticipate we necessarily will, but if we do, I apologize in advance. We are going to start promptly at 8 p.m. So here in about 2 minutes, 8 p.m. Central Time. So go ahead and y'all, if you don't mind, just introduce yourselves. Tell me where you're from, what you do, what your profession is, where you're at in your training, if you're a clinician or if you're still a student. Introduce yourselves, and I'll be following along with the chat as we go through the presentation. So highly encourage questions, any sort of, clarification that might be needed. I'll be asking questions, about differential diagnoses and workup and so forth. So okay, we're going to start about 1 more minute. So since we're on YouTube, we have the opportunity to share and like. So I encourage everyone who's watching to do that, because that way we can get more people on here watching and listening. Use the share like buttons. So welcome those of you who are in the comment boxes here, and everyone else who's listening. BioChick22, Carlos Sue, good evening to you too. Jane, PA, 36 years, ED, clinical trials, Colorado, awesome. First year primary care PA, that's fun. Colorado, I'm jealous. A lot of Colorado people on here. Oklahoma, Arizona, love it. Thank you for your service to Gilbert and Lynn. Anyone else who's military. I recently got back from a vacation to Vermont, and it was fantastic. Anyone else here from Vermont? Because Vermont is a beautiful state, and I just want to congratulate you. on living there or being from there. It's a beautiful place. Singapore. Wow, fantastic. Medical student, Glasgow. Very international. This is great. Toronto, Canada as well. All right, so I think we've got probably all the technical stuff worked out. Got a good sound check here. Let me know if you have any trouble hearing me, any trouble seeing me, or if I know there's a little bit of a lag between what I'm saying and what it comes across on the internet. Definitely reach out, let us know if there's any trouble, and we will get to it right away. So we're going to go ahead and get started with stranger cases. This is the second installment of this. The first episode we did last month went very well. Thank you all for those of you who are involved with that one as well. Excited to do another one here. This one is switching gears. Last time we did an elderly lady. Today we're going to do a case. This is the case of the wheezing child. So, like I said, at any point, just reach out with any questions, feedback, anything to add as well. I know we've got a lot of seasoned clinicians here as well. More than welcome to jump in, add something to the presentation that doesn't have to be a question. Any sort of feedback is awesome. So let's get started. Case. Here it is. Case is a 3-year-old boy presented to the emergency department with a complaint of wheezing and vomiting for 2 weeks. His mother says that he has a history of asthma, albuterol as needed, which provides temporary relief. He was seen by his pediatrician 8 days ago, and he was put on a 5-day course of prednisolone. There has been no improvement overall. He had a little bit of improvement when he uses albuterol, but the overall picture, he's been about the same for 2 weeks. The mother also points out that there's a decreased appetite. Wheezing and vomiting for 2 weeks. What do we got? A little bit more history. The patient's cough was non-productive. It did get a little bit better when he uses albuterol. There was no fever, no chills, no diarrhea, no pain, or dysuria. No known sick contacts. His immunizations are good. The last time he got albuterol was 2 hours ago. Last episode of vomiting was 1 hour ago. Any ideas so far? Here's his review of systems. Kind of a rehash of the history, as it seems like most review of systems are. Coughing, wheezing, vomiting, decreased appetite. Here are his vital signs. And when you look at those are pretty much normal. His heart rate's 114, respiratory rate's 24. If he were an adult, I might be a little bit more worried about that, but since he's a kiddo, 3-year-old, that's within the normal range there. Reassuring that he's 99% on room air. Next up, physical exam. So generally, he's a fatigued-looking child. I wouldn't go so far as to say he looked lethargic. He was mostly just fatigued, really tired. Of course, this was a really late in the night, like something around 2 or 3 a.m., so that wasn't all too shocking. Tell you what, let me go to the next slide where they're highlighted in yellow. There we go. So the oropharynx was red. Been complaining of a sore throat. It was mostly red in my guess, probably due to the vomiting he'd been having. He did have some wheezing. I auscultated his lungs, scattered expiratory wheezing. Otherwise, his exam was pretty normal, though. So, talk to me about differential diagnosis. I see foreign body has been thrown out there. Excellent thought. Anybody else have any differentials or want any more questions in the from the history that I left out, perhaps? Okay, let's move on. Someone's saying pneumonia, foreign body. Good guesses. Here's the differential list that was kind of in my head as I was working this up. Asthma exacerbation. I mean, it's what the mom said when she came in. Asthma exacerbation. This kid's 3 years old, so most would say that you can't really make a formal diagnosis with a child who's less than 5 years old of asthma, but reactive airway disease is a proxy. So even though the patient was, complaining of that when they came in, you got to keep that on the differential. Viral URI, strep, bronchitis, pneumonia. Oh, let me answer some questions that are coming in. Anyone else in the family with symptoms? No. This kid was the only one with symptoms. At this point, there was not a chest x-ray. Poison as the differential. That's a good differential to add. Activity level, able to sleep. His activity level was slightly decreased. He was able to sleep. I would say he was more sleepy than alert. There was no drooling. He was tolerating his secretions well. No recent travel. GERD is a good thought for his symptoms as well, and allergies. Mold exposure, that's awesome. It's another good differential. Okay, so continuing with the differential on my list here, the usual suspects for URI type symptoms and cough, wheezing, pertussis, and croup are a little less common, but they're definitely out there. The gastroenteritis could explain the vomiting, not so much. Posttussive emesis, that's kind of what I was initially thinking. It's fairly common to see that in a patient that's got asthma or reactive airway disease. Generally, sometimes people have more cough than anything else when it comes to asthma, and they'll cough so much that they're vomiting. You see that a lot with pertussis, but you can also see that with asthma as well. Kind of the classic association is with pertussis cough. BioChick22 asking about no barking cough, and I would say no. I did hear the child cough. It wasn't that barking cough like we hear with croup. And the kid also, on my exam, I didn't really mention it much in the previous slide or indicated anyhow, but he looked a little dehydrated. Nothing severe, but he did dehydrated, so I put that on the differential. Okay, so here's what I decided to do with this kid. And I do this with most kids who are wheezing. Start him on a duoneb, give him a breathing treatment. I did, at this point, still consider reactive airway disease to be the most likely diagnosis. So I wanted to give him a breathing treatment. I also gave him some prednisolone. I do this all the time in the ED. I know he's already been on prednisolone at home, but this was a higher dose than what he had been on. I also did some Zofran form because of the history of vomiting, 2 milligrams ODT, and then PO challenge. And that's all I was going to do initially. That's all I did do initially. I did not order labs, and I did not order imaging. For most asthma exacerbations, a chest x-ray is not really indicated as long as things are routine. I think it's reasonable to start with the above, with the albuterol, ipratropium, breathing. You give them a neb and then just kind of watch and see how they respond, make sure that their vital signs stay good. So that's what I did, started that route. So then we got to reassess. This is probably the most important part of treating kids with asthma, is see how they respond to the treatment. If you're going to go that route, think that it's asthma, we have to prove that we can make them better. This patient, his wheezing was persistent. It a little bit, but it was still there. Still no respiratory distress, though. He was able to, speak in complete sentences, no accessory muscle use, no retractions, nothing like that. Got a repeat set of vitals. His temperature stayed the same. Heart rate went up. Respiratory rate went up, went down. And O2 was 100%. So his heart rate going up didn't particularly concern me. Gave him albuterol, which is a beta agonist, so it's kind of normal for that to increase the heart rate. So when we look at this, kind of the next question is, when you're making your decision, he okay to discharge? Is he okay to go home? Everyone would probably agree. This kid, if the wheezing is persistent and he's still coughing a lot as well, probably not a good kid to go home yet. Plus, we have a few other questions. He's still appearing a little bit weak. He still looks a little dehydrated. And then, of course, there's the PO challenge because he was vomiting. And the PO challenge is something that he failed. He was unable to tolerate PO. In fact, the nurse came and spoke to me and said that she tried to give him steroids, wasn't really able to swallow it. Vomited medicine immediately after giving. So, tell me what that sounds like. And I emphasize here the word immediately. I asked the nurse, what exactly do you mean like immediately? Like within a minute, within 2 minutes? She's like, no, like it came right back up. Throw out of the differentials what we're kind of narrowing down at this point, or what's sounding more and more likely, and what you want to order. Chicks want to get chest X-ray, absolutely, great idea. I think the idea of holding off on a chest X-ray at the beginning of what you might think is an asthma exacerbation is a good idea, but if they're not responding to treatment, if there's something that's complicated about it, you want to get a chest X-ray, see if there's anything abnormal like a foreign body or pneumonia. Something in his lungs, like he inhaled a piece of food, food, intussusception, blockage, for all X's. I like that. So the things that were kind of at the top of my differential at this point were some type of obstruction, GI obstruction, like a small bowel obstruction, could be caused by intussusception, foreign body. Also kind of on my radar, but not so much. More the obstruction. His abdomen was benign, though, as I meant before. But we definitely need some imaging. Everyone's agreeing. X-ray, possible solumedrol. I agree with that. Solumedrol may act a little bit faster, kind of soft tissue neck. So yeah, when we're going the route of looking for foreign body, you want to get all the way from the mouth and look at everything. You want to see what it is. I like what Dan Walker just said, anaphylaxis. That's an awesome thing. I don't think anyone's said yet. If you have, I'm sorry I missed it. Anaphylaxis is something you should always keep in the differential, especially when there's any sort of airway stuff. Wheeze can definitely present as anaphylaxis. I was thinking about it. Don't think any of the findings so far made that at the top of my list, but I was definitely keeping it. Vomiting was not good question. Okay. So what next? Everyone agrees. Let's get some imaging. I ordered an abdominal series and a chest X-ray. Here's what the abdomen showed. So that's a swing and a miss. Swing and a miss. This is a normal abdominal X-ray. Normal, just we'll move on to chest X-ray. It's like normal bowel gas pattern, no air fluid levels. Bowel loops are non-distended, no free air under the diaphragm at all or anywhere else, and no foreign body. Next up, chest X-ray, and boom, diagnosis made right there. So what is this? Where is this? Can anyone tell me just from this picture? I know we've all learned it at some point, but does anyone remember where we might think this is located? Yeah, so in this picture, what we're looking at is something that's like perfectly round. This looks like a coin, like a quarter, something like that. Can anyone tell me where it is, though? D. Reeves O says, is it a battery? Nick Ritchie says esophagus. Connie NP says above the carina. Quarter in his esophagus. So this is located in the esophagus. The reason we know that is the face of the coin is oriented in the AP direction, so it's facing us as we look at this PA film. If it were in the trachea, generally it's going to be oriented more laterally, to where it's facing laterally, so it would look more vertical in the view here, like we'd be looking at the skinny side of the coin. So yeah, this was an esophageal foreign body. Very, very alarming when I saw this, honestly. Because initially I was like, oh, it's just an asthma exacerbation when the kid first came in. But yeah, when I saw this, I was like, wow. The mother was also shocked when I told her. The patient's been having symptoms for, she was having symptoms for 2 weeks. And so I assumed the foreign body had been in there for that long, but the mom was just horrified because she felt so bad because she didn't know. They didn't really know how long it had been there or how it got there or anything like that. Now, I do want to mention this picture that I used on here is one that I obtained from the internet. It was not the actual patient. The patient that I saw, it didn't really have this perfectly smooth circular margin it was circular, but the edge wasn't smooth. It was kind of like rough around the edge, and it looked more like a bottle cap. It had one of these, kind of sharp edges around to it like this, and I was thinking, my goodness, that is not good. If it were a coin hanging out in there, a little bit less worried about a perforation of some kind. Although the fact that it was in there for 2 weeks is a little bit more worrisome. But these sharp edges made me really nervous. I'm like, that could definitely more easily perforate than a run-of-the-mill coin. Someone mentioned, Brandon a few lines ago says a battery would have a halo. Is that correct? And that is correct. That's what I wanted to talk about in just a moment. We'll definitely get to that. But yeah, I think everyone's kind of jumping on board with me here. Like the 2-week thing is what really threw me off. I was like, symptoms for 2 weeks. So yeah, for esophageal foreign bodies, the classic signs and symptoms, anorexia, dysphagia, drooling, vomiting, wheezing, stridor, roughly 50% are asymptomatic initially. And then as far as diagnosis, it's just imaging to see what it is, to see where it is. And like I said, we image. So I want to talk about these button batteries. They look different on X-ray. They've got this kind of double ring appearance. You can see it really well on this X-ray here. Why does it matter? It matters for the reason that you can actually, this is a very high risk foreign. When both sides of the button battery touch the mucosal lining, it actually is able to conduct electricity and actually lead to necrosis very quickly. You have a high risk of developing a perforation, fistula, or a burn. So that's a 4-alarm fire that needs to come out immediately. The other thing that really needs to come out quickly are these crazy strong, teeny tiny magnets, these rare earth magnets. Y'all have probably seen these before. Probably been taught this before too at some point, but just as a review, 2 of these magnets that get swallowed can become attracted to one another inside the GI tract, and you can get pressure necrosis, perforation, fistula, obstruction, etc. It can cause big time problems. So that's something to definitely keep in mind. All right, so how do we manage these? I think someone mentioned before that this happened to a family member, a friend's kid. She was okay, able to pass the foreign body on their own. That's honestly what happens most of the time. Let's say this was a coin or something benign, not a battery, not a magnet. Most of them are going to pass on their own. Only about 10 to 20% require endoscopy to go down and get it. Spoken to a GI doctor about this before. He says, for the most part, if it makes it through the esophageal sphincter and into the stomach, it's got a really good chance of making it all the way out. If not, though, it may require upper endoscopy to go down and get it. Usually not emergent. Usually it's just kind of more of an urgent thing, like do it within a day or so. However, this is certainly something you want to call GI, have a conversation with them about it, how to manage it, how long to wait, if waiting at all, depending on what the object is, how long you think it's been there, what the patient looks like, etc. Emergent endoscopy, if it's a sharp object, magnet, button battery, like we talked about, if there's any sort of airway compromise, even if it's in the esophagus, you can get airway compromise, needs to go get it right away if the patient can't tolerate it, go, or if it's been ingested for greater than 24 hours, it really should be gone after emergently. Go get it. I had a patient one time who the parents came in and they told me that the patient had swallowed a thumbtack. And I was like, well, that doesn't sound good. The x-ray did come back and there was a thumbtack sitting in the patient's stomach. And you can see the very sharp, pointy part of the thumbtack just hanging out in there. And it made me super nervous. I was like, no one touched this child. And so I wanted to arrange to get them transferred over to a pediatric hospital where they could get it removed, CGI emergently. I call over and I speak to the emergency physician who's answering the call, and he's like, honestly, we usually send those home. I was like, a thumbtack? You send that home? Like, yeah, if it's in the stomach, if it's made it through the esophagus and it's hanging out in the stomach, most of the GI docs won't go after that, at least not at this particular hospital. So I felt super uncomfortable about that. I spoke to the physician I was on shift with. I was like, does that sound right to you? And they're like, no, that sounds kind of weird. So the physician at in the ER at the peds hospital was like, all right, I'll call GI for you and consult them just to kind of, loop them in and make sure they agree. And he did, and the GI specialist was like, yeah, they can just follow up in the office in the next day or two. I was like, wow, okay. Documented that chart very thoroughly. Got the mom's phone number. Very strong ED precautions, and the kid was totally fine. He passed it. No perforation, no problem, no bleeding, nothing, no pain or anything. But yeah, I was calling the mom like twice a day. Did it come out yet? So that was an interesting case. And a good example of if it makes it through the esophagus, it usually makes it out. So as far as this patient, that followed the bottle cap. The patient was transferred to a children's hospital. I think they were concerned, like I was, because this thing had been in there for potentially 2 weeks. That's how long the patient had been symptomatic. They got upper endoscopy and removed it, and it was a bottle cap. The patient was able to be discharged home the following day. They just odsed the child overnight to make sure everything was good, and everything was. So that was what happened there. All right, so I want to go over some key takeaways from this case, because I think there was a lot of good ones. Wherever y'all are practicing, I'm sure it's just as common as it is here in Texas. Asthma is very common, and you hear a lot of wheezing. There's a mantra that we've heard before: not all that wheezes is asthma, and it's very true, such as in this case. Honestly, this kid did have reactive airway disease, but foreign bodies can also cause wheezing. Not to mention if they're having foreign bodies and having a lot of vomiting, you can get some aspiration of that vomit and could definitely irritate the asthma even more. But not all that wheezes is asthma. Here's a list of things that cause it other than asthma. Bronchitis, bronchiolitis, such as RSV. Pneumonia can cause wheezing. Allergies and anaphylaxis definitely cause wheezing. Gastroesophageal reflux disease, GERD causes it. CHF can cause wheezing, which does happen in children sometimes. That fluid buildup in the lungs and can cause wheezing. And then any sort of mass, whether it's a tumor or a foreign body, anything that's going to alter the way flowing through the upper airway and the lower airway. If it's upper airway, it's more likely to be something like stridor, voice changes. Lower airway, you're going to get things like cough, wheeze, etc. Another key takeaway: response to therapy, especially when you work in the emergency department or maybe you work in an urgent care, anywhere where you're performing interventions on patients and then deciding if they can go home or not, deciding if they're okay. You have to really pay attention to, does the therapy that we tried here actually work? If the cause of the patient's symptoms had been asthma in this case, then wheezing probably would have gone away. The patient probably would have been able to tolerate PO once we get the asthma under control. Neither of those things was true. So that prompted me to kind of search further. And it was a good lesson for me, a good reminder for me too. That goes for any complaint, not just asthma or wheezing. It goes for abdominal pain, it goes for chest pain, it goes for headache, it goes for a lot of different things. If you can, that you can make the patient better clinically, and it can be for a given differential diagnosis. And you always want to document that on the chart too. Another key takeaway: chest x-rays, not routinely indicated in asthma exacerbation unless there's an unclear etiology or complication that you may suspect. So that was the case here too. I mean, there was something unclear going on. So I don't normally order chest x-rays on asthma exacerbations unless they've got like a high fever, unable to tolerate PO, if they look really sick, that sort of thing. Beware of the sudden onset stridor or wheezing. That could be a foreign body. It comes on gradually, it could still be a foreign body or something else. If it just starts immediately, like 1 minute they were doing it, mom looked away, and then now they've got stridor all of a sudden, they probably, swallowed a foreign body or aspirated a foreign body. Next key takeaway: esophageal foreign bodies that are button batteries, magnets, sharp, too large to spontaneously pass, or if they've been present for over a day, or if you're not sure how long they've been there, should undergo emergent endoscopy. And I would argue that if you plan on sending a patient home with an esophageal foreign body or any sort of foreign body in the GI tract anywhere, I would probably make a phone call to GI just to either arrange good follow-up, or if they decide they want to see them tonight, they can, or today, that's fine. Lastly, pediatric patients. I always try and stress this. They should have normal functions before you discharge them. So what do I mean by functions? Can they eat? Can they drink? Can they urinate? Can they defecate? Can they breathe? Are they breathing well? Is the wheezing under control? Any respiratory distress? If a kid can't do these things, we need to work it up. We need to try and figure out why. We need a good explanation for it, and we never want to send a kid home who's not doing one of these functions. So that's always a good indicator. At least in the facility where I work, likelihood of ordering blood work, or CT scans or anything like that on children, you're less likely to do that than you would be in an adult. We rely on these basic functions of a child to kind of help us figure out, are they sick or not sick, a little bit more than we would in an adult. That's usually because the kid has no past medical history most of the time. Adults tend to. But anyway, we look at these things and it helps us out a lot. Okay, so I want to hear some questions from y'all. If you have any comments, any questions, any feedback. Mariella Benavides, ENT consult. An ENT consult here would be indicated if it were a little bit higher up. Where this one was located, it was in the esophagus, so that's kind of in the GI territory. What other questions do y'all have? Any other comments? Connie asks, what specific x-ray do you order to rule out a battery? So honestly, it's the same x-ray that you would order for any potential foreign body or signs of obstruction. If it's a really little kid, a lot of the radiology technicians can get like basically one picture, including the entire picture from mouth all the way to anus. If it's like an infant, you evaluate for foreign bodies with one single picture. If it's a little bit bigger kid or even an adult, you may have to get several. So what I would do is I would get a lateral neck film, then a chest x-ray, and then an abdominal series. And it's best to get AP and laterals for each of those to help identify the object as well as the location. But identifying a battery, you can see that double halo sign, that double ring sign on just a regular plain film x-ray. If they swallowed plastic, would that show up? Good question. I think the textbook answer would probably be no. However, I have seen plastic show up on x-rays before. It's not as clear as metal. It all depends on like what exactly the object is. In general, plastic is not radio opaque, so it won't really show up that well. You can sometimes see a distortion of the regular anatomy because there's a foreign body there, even if you can't see the actual foreign body itself. So I would say, generally speaking, plastic does not show up very well, but I have actually seen it before. I don't know if maybe this plastic had some other material that was mixed in with it or something, but generally no. Let's see. The Cat Doc 54 soft tissue technique on smaller children, button batteries may not have halo appearance. Oh, I did not know that. Okay, so I guess what you're saying, Cat Doc, is that you may need to order not the soft tissue film to see that double halo sign. Excellent, I did not know that. Happens more often than you would think. Yeah, I would believe that, Lynn, that in the urgent care setting you see this quite a bit. Absolutely. This is from Shane. Was the patient unable to tolerate any oral intake for 2 weeks, i.e. vomiting after every meal, or was it just to the PO challenge in the ER? We're having trouble with oral intake for 2 weeks. That symptom that I saw in the ER for the PO challenge that the nurse told me about, apparently that had been going on for 2 weeks. And I think that's part of the reason why the mom had a very when I told her what the diagnosis was. Felt really bad because she was a really sweet lady. I could tell she was a great mom. She did take her kid to the pediatrician already, and it's not like she was ignoring this. So she knew something was wrong. But yeah, she told me, obviously once you know the diagnosis, you kind of go back and retrofit your history by asking more questions and can clarify. So I was asking her like more about that because I didn't want to miss it in the future. It's like, was the patient able to drink or eat anything? And the mom was saying that he could take little sips, little pieces of food, very small. But if you gave him anything, a lot at a time, it was coming back up. I think that's what made me think, okay, this has actually been in there for the full 2 weeks because that symptom was there for 2 weeks. Any other questions? Any other feedback? I really appreciate y'all joining tonight and participating with the case. I really enjoy doing these. So, and we always, are open to feedback, of course, for ways to make it more relevant, more helpful, focus on different aspects, get better for y'all. These are a couple of the websites that I want to direct you to. Anyone who listens to the podcast, that's me talking on the podcast. If you want to send any questions, go to askmedgeeks.com to get questions answered. So if you have feedback for this presentation, I can see that there as well. Also, of course, go to our website, medgeeks.co. You can find us on Facebook, Instagram. ShareBear133 asks, oh, this is a good question. I should have thought of this for the presentation. Pretend the foreign body was not radio opaque. What would be the next step given continued symptoms? Well, I would say in that case, the child should definitely still not go home, especially if they're not really taking PO well, because the child already looks dehydrated. So for just that reason alone, foreign body not radio opaque, I would say they need to be brought in for observation, GI consult for intractable vomiting. I don't know how they would necessarily manage it. I don't know if they would just do for endoscopy. If symptoms persisted, they probably would. You could also bump it up to a CT scan, but then again, if it wasn't radio opaque on chest X-ray, may not be the best idea. CT, but probably an upper endoscopy would eventually be done due to the intractable vomiting and unable to maintain hydration with PO alone. So that's what I would recommend, or that's what I would say was probably would be the next step, would be admit and do GI consult emergently. Okay, any other questions? Any other feedback? I've already been preparing next month's Stranger Cases episode, and it's going to be interesting. It's going to be different than this one quite a bit, actually. And it was a case that I just recently had about 2 weeks ago. And as soon as I saw this patient and she had this, interesting presentation, I was like, yeah, I'm going to do this on my episode. So look forward to that. It'll probably be in about a month. Okay, any other questions? Any other comments or anything? If not, we're probably going to sign off here in just a few minutes. I'm going to probably turn off the webcam here, but I'll still be sitting around for a few minutes until we disconnect. So if you send in some questions, we'll still be able to see them. Just want to say once again, thank you all for joining. I really appreciate it. And I will see y'all next time.